Cardinal movements of labor. A legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational use only, not intended to substitute for professional, legal, or clinical advice. We strive to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. The course objectives, the student will be able to verbalize what exactly are the cardinal movements of labor. They'll be able to verbalize the 7 different movements that help to bring the babies out into the world through the mom's pelvis. They'll be able to verbalize various positions they can put the mother in to allow that rotation to happen and decrease the time of labor and decrease the time of pushing for a successful vaginal delivery. Why is this topic important? It's really important because we have a high C-section rate in the United States, and a lot of times we're not getting women in the best positions for their pelvis and for the labor stages that they're in. We set them in a bed, lay them on our back, they have too much pain, they get an epidural, and then the baby can't rotate. And so midwives and out-of-hospital births, birth center, home births are the experts in cardinal movements of labor and helping to get mom in great positions and even allowing her instinctual side to take over where she does what her body is telling her to do versus the system is telling her what to do. So we're going to go over the different cardinal movements of labor and that spiraling down rotation that the baby does to have descent and eventual delivery through the birth canal. So let's go to the basics. What exactly are cardinal movements of labor? It's the mechanisms, the mechanics of the labor process. I think too many times people think they just come shooting straight out, and they're actually doing a corkscrew effect, and they're rotating in the uterus, in the belly, and in the pelvis when they come out. The head is slowly spinning and getting the shoulders in a right angle for that mom's pelvis. So the first stages and the second stages of labor, so before the baby's actually delivered, it's that twisting and corkscrew rotation that's slowly happening as the baby is passively moving through the birth canal with the contractions. So changing the baby's position, changing mom's position allows to get the baby's head in an optimal position. We get a lot of times, yes, the baby's head down, but the baby is posterior, meaning it's looking up at the ceiling during delivery, the mom's pubic bone versus her rectum. The baby is asynclitic, meaning that it's a little tilted in the pelvis. It's not the optimal part of the baby's head, which increases the circumference of the angle that the baby's head is trying to come out, and it doesn't mold as well. So we get a lot of ladies that have C-sections because of that failure to descend, which is the baby didn't get into those good cardinal movements of labor because of some situation, whether it's the positioning wasn't adequate for the mom's pelvis to change the angle. There are rare times that the baby is just too big to go in the pelvis, but I think many times we're just not good at understanding the cardinal movements of labor and her unique pelvis and getting the baby to continue rotating and descending in the pelvis. So the 7 cardinal movements of labor, you have engagement. That is when the baby is directly in the mom's birth pelvic canal, ear to ear, and the head is starting to engage. It's not ballotable. We can't use our hands during a vaginal exam or fingers and push the baby's head up anymore. Well engaged means that the baby's head is sitting at the top part of the pelvis and is starting to descend for the birth process. The widest part of the head has entered the pelvis. It's the starting of the birth process. The mom says she has a lot of pressure. It's definitely, if we have people that don't even get past the engagement phase, we always worry about a narrowed inlet. We always worry about a large baby. We always worry about a short cord. Something else is happening why that baby isn't even engaging in the pelvis. If we're checking and checking and checking her and the baby is at -2, -3 station, ballotable, she's got strong contractions and the baby isn't even just coming down with all her great positionings, we start thinking as midwives and healthcare providers there's something more going on. Descent and flexion, the baby's head must descend deep in the pelvic cavity. Their little body starts to begin to form, kind of squish together the shoulders, and starts descending directly into the pelvis itself. Flexion and descent go hand in hand. This movement is a result of the baby's head sitting on that soft tissue of the pelvis, aligning the head with their chin, so they're kind of tucking their chin down so they can get the optimal part of their head position, and starting to get deeper into the pelvic cavity. Squatting, sitting positions, depending on if you have like a birth ball. Firm surfaces tend to narrow the pelvis, but soft surfaces, especially like the birth ball where they can rock their hips, squatting, really opening up the pelvis allows for that descent and flexion to making labor shorter, more comfortable, and that baby, when the contractions are coming, to be able to put their head in the pelvis more easily. So birth stools, birth balls, squatting are great things for that early active labor. Internal rotation. So we're getting close to delivery now. We're in the pushing phase. We're at the point where we can see the baby's head starting to crown, and the internal rotation. You actually can watch during pushing, the baby's head is still continuing to rotate in that corkscrew effect. It could be transverse, it could be anterior occipital, it could be a lot of different, but you just watch, you can feel it too, but it's just an amazing process. They don't just come shooting straight out. They continue to rotate with their shoulders to get the optimal angle in the mom's pelvis. So the head reaches the pelvic floor. It rotates to accommodate the pelvis dimensions, the diameter, and it's an internal rotation. It's the point where the baby is at the lowest part of the pelvic floor and the head is fully rotating to come out. Standing upright, slightly bending at the knees is the best way for that very end part to really give the most angle of the pelvis, to help with delivery of the baby. In the hospital setting, unfortunately, it's a lot of lithotomy where they're laying down, semi-lithotomy, where they've got the head partially up, stirrups, and you're narrowing the pelvis. Your hands and knees, squatting, those more upright positions, a birth stool, are really the ones that are helpful, and you have far less shoulder dystocias, far less pushing times. There's a lot of benefits to really opening up the pelvis, and you'd be shocked. Every little millimeter, every little angle change you make makes a world of difference. Extension, so the baby's head is now delivering and the baby is fully rotated and descended, and then the head passes through the pelvis at the base of the neck, and you're starting to, this is typically, the head is pretty much delivering large crown, and then you're starting to get the shoulders to rotate in the pelvis. Sometimes that'll happen at the same time that the head is delivering in one smooth motion that the baby comes out, especially if they've had babies before. First time moms, larger babies than her last baby, it tends to be the head comes out and then you have a pause for the next contraction, and then the shoulders will rotate. Obviously, if there's signs of shoulder dystocia, the turtling, there's purpling in the face, the tightness on the shoulders versus it's sitting at the perineum loose and relaxed, you're going to do some maneuvers. But many times we act like there's a shoulder dystocia in the medical world, and it's really just the normal process of birth, but we don't understand the cardinal movements. We don't understand the normal birth process. It's a lost art in our main hospital systems. The midwives in birth center and home are the experts still in this, because we don't have epidurals. We don't have those medical standards in part of our practice. We do physiological birth. So you definitely want to make sure you get her in the position. Some women will like to lay and be sidelines because their legs are tired. It's whatever they're most comfortable, and as long as it's making descent and progress, the mom is in charge of this birth process. External rotation, the head is born. Now we're talking about that point where the shoulders are rotating. Sometimes it's one smooth, quick motion. The external rotation may be the same time after the head delivers. You don't need the next contraction and the baby just delivers. It might be a pause between contractions, and then you have the external rotation. And so the baby's face needs to move either direction, to the right or the left, depending on which way the shoulders are trying to fit through the pelvis and under the pubic arch. This phase, you definitely want to do some breathing techniques. You want to allow, there's a ton of burning, stretching, pressure the mother feels. And some women, as soon as the head comes out, they feel 1,000 times better because the shoulders are typically much easier to deliver than the head is. So if she's feeling the urge to push, you don't stop her. But if the contraction's over and you're not seeing any signs of a shoulder dystocia, you just let the baby sit at the perineum, and then the next contraction, that external rotation, is going to happen. Expulsion, this is the part everybody loves. This is the part where the baby is actually coming out of the mother's body. It's the movement of the shoulders past the pubic bone and the delivery is occurring. It may be easy, it may be more of position changes and some maneuvers that the midwife has to do, the birth provider, but it's the very tail end of the delivery process. And this is the one where everybody is super excited, euphoric high. The baby gets to be put on the mom's chest, and it's the final stages of the cardinal movements. So we're going to talk about the helpful positions you can get your client into to help. I think too many times labor and delivery nurses, doulas, midwives, physicians, we don't have enough tools in our tool chest. Maybe some stairs would be great, but you're on a labor and delivery unit and she can't leave the unit to do some stairs. How do you creatively solve that challenge with the equipment and resources you have? So I like with home births, because there's so many tools, we can have them do the steps, up and down the steps, every other leg. It'll help make strength in the contractions. It'll help rotate the baby, especially if they've had a baby before and they're closer in that transition. It gets really close to pushing time that way. The rebozo technique, a lot of midwives in out of hospital are familiar with it, to help on the abdomen with a cloth to rotate the baby. But in the hospital setting, these are kind of lost arts and we have limited tools. They'll use a lot of peanut balls with epidurals, but the bed can go into different variations, but they just don't have the space and they don't have the tools like an out of hospital birth does. So most labor and delivery units and home birth centers, you have the option of utilizing a birth ball. It's really powerful in that early stage of labor, early active stage. You want to get those hips to rock and not burn all of her energy when you know there's a long birth process going to occur, especially a first-time mom. So it allows to tuck the tailbone, it narrows the sits bones, but it opens up the pelvic bone. It's that external rotation of the femur bones known as the Buddha Kansana. So you want to be able to, in the early stages, help to get the baby's head engaged in the upper part of that pelvis, the inlet. For mid-level, so this is good active labor. That's when I talked about doing the stairs every other step. Like you could do a lunge in the hospital, you could find a chair and you could have her rotate back and forth doing this position every 15-20 minutes just to change the angle of the pelvis, and during the contractions doing some subtle hip rocking. You could do side lunging. It just depends on how active she is, how long the labor's been going on, the strength of her legs. If you have a person that does yoga, they exercise all the time, birth process is going to go so much easier for them because birth is a marathon. You're using a lot of muscles and doing positions you normally wouldn't do. If you have ladies during labor that are more sedimentary, they do desk jobs, they don't exercise, birth is a lot harder for them because their muscles get tired easily, they cramp, they've got lactic acid buildup. There's a whole other challenge with their birth process, being able to have the strength and endurance to do all these positions and to support the birth process. So for the lower outlet, you're getting in more that transition, close to pushing phase. A lot of people will do hands and knees, squatting, ways to get that outlet, the lower part of the pelvis, to really open up. Hip squeezes are great at this point, changes the angle of the pelvis. This lady and her daughter in the picture are doing some yoga and some exercise and showing you how to do the high squat where your tailbone is kind of more arched out and that backwards rotation. And you can do definitely hands and knees and put a pillow under her belly if she's more tired. So you're trying to get that outer part of the pelvis really open so that the head can continue to descend. So as a conclusion, the baby's position is very, very important through the birth process, especially when we're talking about physiological birth. The head is the biggest part, and it has to constantly be rotating in a corkscrew effect to be able to descend in the pelvis and have a shorter labor and a shorter pushing phase for the mother at hand. So there's different positions to try, and there's one that's not better than another, especially if the mom is doing instinctual birth. And a lot of midwives try not to give it guidance unless it's a variation of normal. We try to really allow instinctual birth to occur, and the mom will naturally do the positions that allow for cardinal movement of descent for the baby, and it's really powerful to see. So if you have the opportunity, just try these different positions yourself. Teach your clients, your patients during prenatal visits the cardinal movements of labor and why it's important to move during labor, and the different positions they can do, and the different ways you can help support baby coming down in the birth canal for a successful vaginal delivery.